Namaskar and good evening, everyone. I welcome you all on the second day of Onco Bridge 2025. And with immense pleasure, I would like to invite Dr. Asim Kumar Samar, who is Senior Consultant Medical Oncology at BMCHRC Jaipur. Over to you, sir.
Thank you very much. So let's begin the second day of this webinar, that is Onco Bridge 2025, where we will discuss the recent updates in the field of various eminent cancers. So first day we discussed with the GI cancers. Now on the day two, we will discuss with the GU cancer. And as you all know, the GU cancers, genitourinary cancers, are in the big move now because of the invent of some targeted therapies, antibodies, antibody drug conjugates, and immunotherapy. So everyone wants to learn how they are acting in the trials, what are the results, and what best we can do with our patients. Furthermore, various combinations have emerged in the arena of the GU cancer and the urinary bladder cancer. So we will discuss today all of these. Most of these the eminent trials which have given the result in the last 6 months, not year, because we are going to give the recent updates. So this is the motto of our journey and learning. And GU cancer, why it is important is it is often understood like misunderstood, like they are rare cancer. But nowadays it is very common because of our lifestyle habits, addictions, substance use, and somehow stress also, or eating patterns. So it is becoming more common in the society, and once they happen, they are almost lethal, and the patients are always very symptomatic whether you give treatment or successfully treat the patient with the all modalities. And other departments also contribute in some way in this cancer. So our role is to generate precise data in the adjuvant setting, neoadjuvant setting, maintenance therapies, metastatic setting. So we will discuss all these settings in the particular cancers. So first of all, for the opening, I would like to invite my dear colleague, my best friend, Dr. Ankit Agrawal. He's from Jaipur, Udaipur, and he's a consultant medical oncologist in the Gitanjali Hospital, Udaipur. So he will be speaking on the TelaPro Trial 2, Telazopari plus enzalutamide, whether it improves OS in the metastatic CRPC with significant enhancement in the enrichment in HRR population. So he'll be speaking in a very untouched topic. So over to you, Dr. Ankit.
Thank you, sir. Thanks a lot. It's always a pleasure to be a part of your conference. And
Thank you.
I'll just share my screen. Just give me 1 minute, please. I think there is some problem. Can anyone share my screen, please? Is it possible? I think I'm facing some issues. Yeah. Okay.
Screen is visible, right, sir?
Yes. Okay. So without wasting further time, I think I have 7 minutes to talk about the trial, TelaPro 2 trial. So basically, this is a phase 3 trial of first-line talazoparib in combination with enzalutamide in metastatic CRPC setting. Next slide. So next slide, please. I'll just go briefly. I'll discuss about the background. Why was this trial basically done? Why was this? Why do we combine a PARP inhibitor with androgen receptor blocker? And we want to find out what exactly is the result of combination of a PARP inhibitor with an androgen receptor blocker when it is compared with an androgen receptor blocker alone in a patient who has metastatic CRPC. So basically, the previous trial was the TelaPro 1 trial, which was a phase 2 trial. They found out that talazoparib, being a PARP inhibitor, has around 30% response rates. Even in those patients who are heavily pre-treated, metastatic CRPC patients, even if they were heavily pre-treated, still those patients who were HRR mutated, they had a response rate up to 30%. and that became the basis of use of talazoparib in the phase 3 trial. There were preclinical studies that suggested that probably when you combine talazoparib or when you combine a PARP inhibitor with an androgen receptor blocker, both of them, the mechanism is such that they have a synergistic effect in causing the lethality to the tumor cells. So basically, PARP inhibitors, what they do is they basically upregulate the activity of the androgen receptors, and thus the androgen receptor blocker, the efficacy increases. Similarly, vice versa, when you use an androgen receptor blocker, they downregulate the HRR genes, and then environment is created in such a manner that the PARP inhibitors can act very easily in an environment where already a downregulation of the HRR genes has happened. So that is why this was the basis of combination of these two agents, and that is why this was the design of the trial. Now, basically, one more thing came out of this synergistic activity is if the patient is not HRR mutated, will that combination be effective? And hence, what happened? The Talapro-2 trial, they used talazoparib with androgen receptor blocker, that is enzalutamide, in all those patients who had metastatic CRPC, irrespective of their HRR mutated status. Next slide, please. So this was the study design. It is a placebo-controlled phase 3 trial, double-blinded and randomized. The selection was patients newly diagnosed with CRPC, ECOG performance 0-1. Samples were prospectively assessed for HRR gene alterations. And it was basically, they were stratified on the basis of their prior treatment by either abiraterone or docetaxel for castrate-sensitive prostate cancer. HRR gene status was also included as a stratification point, whether the patient who have HRR non-mutated genes versus HRR mutated, what was the difference in the response. The primary endpoint was radiological progression-free survival. There were two arms. The first arm was talazoparib in combination with enzalutamide. The second arm was a placebo with enzalutamide. So basically, they wanted to know whether a PARP inhibitor in combination with enzalutamide, especially talazoparib, was it better than use of enzalutamide alone in a patient who is not, whom we don't know what is the HRR status. Next slide. So this was the baseline characteristics, well matched between the two arms. Median age was 71 years. As you can see, only 21% of the cases in those, in all the population, around 21% were the patients who had HRR mutated genes. 80% of the cases, either the mutation was not known or these patients did not have any mutation in the HRR genes. Next slide. So this was the outcome. I think basically the primary endpoint was a radiological progression-free survival, and the median radiological progression-free survival in the combination arm was not reached, versus it was 21.9 months in those patients who received placebo plus enzalutamide, with a hazard ratio of 0.63, suggesting a 37% reduction in progression when combination was used as compared to enzalutamide alone. When it was stratified as on the basis of HRR status, those patients who were HRR deficient, they had a much better improvement in the radiological progression-free survival as compared to those patients who did not have HRR mutation. So basically, HRR deficient status patients, the radiological progression-free survival was close to 28 months versus 16.4 months in those patients who received enzalutamide alone. Hazard ratio being 0.46, suggesting a 54% reduction in the progression when combination was used versus enzalutamide alone. When the similar results was taken out for those patients who had HRR non-mutated status, the radiological progression-free survival was not reached in the combination arm versus 22.1 month in those patients who had enzalutamide with placebo. And the hazard ratio was slightly inferior as compared to those patients who had HRR deficient status, but still it was significant, 0.66, suggesting a 34% reduction. So there was consistent radiological progression-free survival benefit was seen with combination arm in all the pre-specified subgroups. Next slide. The median time to PSA progression was also significantly better in the combination arm as compared to the placebo with enzalutamide arm. An overall response rate of 61.7% was seen in those patients who had received a PARP inhibitor, that is talazoparib with enzalutamide, versus 43.9% of overall response rate in those patients who had placebo with enzalutamide. Next slide. Coming to the safety profile, yes, the combination arm had a higher toxicity as compared to the single agent or a placebo with enzalutamide. Almost every patient had some sort of side effect, with the most common side effect being anemia, neutropenia, and fatigue. Around 75% of the patients in the combination arm had those interruption of talazoparib because of the adverse effects, and those reduction of talazoparib was to be had to be done in 56% of the cases. So you have to keep it in your mind that probably if you are using a full dose of talazoparib, you might have to reduce it to a lower dose, that is 0.5 to 0.35 mg. The most common treatment emergent adverse effects leading to dose reduction, as I said, was anemia, neutropenia, and thrombocytopenia. Anemia being seen in 43% of the cases, which is a very common side effect that we see with PARP inhibitors. Next slide. As you can see, 65% of the cases had some sort of anemia, 35% of patients had neutropenia, fatigue was seen in 33% of the cases. So there was one case of MDS that was reported during the safety reporting period. Pulmonary embolism was seen in 10 patients, that is 2.5% of the patients in the talazoparib arm. Next slide. So what were the conclusions of the investigators? They concluded that the combination arm talazoparib with enzalutamide significantly improved the radiological progression-free survival as compared to the placebo with enzalutamide arm in first-line CRPC setting. There was a clinically meaningful radiological progression-free survival improvement in both all-comers population and the pre-specified subgroups. It also showed benefit in patients who did not have an HRR gene alteration. Safety profile was manageable through those modifications, and they have concluded that probably it can be used as a first line setting regardless of HRR gene mutation status. I think I'll conclude my slides here.
Okay, thank you, Dr. Ankit. Thank you
Yes,
very much.
thank you, sir. Thank you.
So, actually, as olaparib also does the same thing, ML and MDS complication, and we all see the anemia is the eminent complication of the this one olaparib. I guess talazoparib is no less. The incidence of having like 26.8% in the olaparib setting, if you
Yes,
give full dose,
yes,
here it is. They
yes.
said like 1%, I guess, huh?
In MDS, they saw MDS in 2.5% of the cases.
They can be correct.
1%, sorry, 1% had MDS.
Six. Yes, yes.
One
Yeah.
one percent had MDS. Yes, 1% had MDS. That was 1% actually. So that was also reported in the safety reporting period. So they were not very sure whether it was basically because of talazoparib or not. I
Okay,
think
and but the other thing is 2.5% patient had the pulmonary thromboembolism,
yes,
which is little bit the problem of concern.
yes,
Uh,
absolutely. That is of concern.
because these are the older patient, they are on the various other medications also. Most of the time they may be on the resting position, so this complication may happen more in the real world, because in the trial setting they are taking the patient of PS0 or 1. We are taking the patient in the PS2 or 3, mostly the 3. So this
Absolutely.
will be problem. Okay, but it is a nice study. So thank you very much, Ankit.
Thank you, sir. Thank
Thank
you for
you.
having me.
Yeah, thank you. Now I will move to the next speaker, that is Dr. Neha Gupta. She is a consultant medical oncologist in the RGCI Delhi, and she will be speaking on the ENJA P study. Lutetium 177 PSMA plus enzalutamide improves RPFS, OS, or quality of life in MCRPC. So, Dr. Neha Gupta, over to you.
Thank you, sir. First of all, I will thank the organizers for giving me this opportunity to speak on this topic. Is my slide visible?
Yeah, you can do full screen, I guess. Huh?
Uh,
Dr. Ne-
yes, sir.
Okay, take them if they can. You can see that. Okay, you can start now.
Okay, sir. So, wait a minute. We'll be discussing the trial in which they have seen overall survival and quality of life when we combine the lutetium PSMA therapy along with enzalutamide versus enzalutamide alone in metastatic CRPC settings. So this is basically a phase 2 trial, a multi-center study which is being conducted in Australia. So this study was designed looking at the previous study. In this graph, we can see that in this study, enzalutamide was studied along versus placebo and in metastatic CRPC settings. As we can see the beautiful separation of the curves when the enzalutamide was given in first line in mCRPC settings with hazard ratio 0.17, which is favoring enzalutamide over placebo in metastatic CRPC settings. And after that, another trial was conducted in which lutetium therapy was compared with the another ARPI inhibitors in metastatic CRPC. As we can see in the curve, that beautiful separation of the curves in radiographic progression with survival was seen when lutetium therapy was given versus androgen receptor inhibitors was combined. So looking at both these studies, the trial was designed combining both of them, enzalutamide plus lutetium therapy versus enzalutamide alone in metastatic CRPC settings. In this study hypothesis, it is being seen when enzalutamide was given alone. So with time, we can see that the cells which were sensitive became resistant to the cancer cells. So when we have combined both the therapy in this lutetium therapy plus enzalutamide, we can see the resistant cells converting into the sensitive one. The CRPC cells were responding to the therapy, improving the survival and the quality of life in these patients. So we'll be looking further in which we have seen the combination of the lutetium with enzalutamide versus enzalutamide alone in metastatic CRPC settings. On this eligibility criteria was mCRPC patient with PSA rising and more than 5 nanogram per ml, and no prior chemotherapy was given for mCRPC patients. And they have taken the patient who has more than or equal to 2 risk features for early enzalutamide failure, and the patient with positive gallium PET scan were taken. In this, they have randomized into 2 arms. One is enzalutamide 160 mg OD versus enza 160 mg plus 2 to 4 doses of lutetium therapy, that is 7.5 becquerels. Objective of the study was to see the primary endpoint was to see the PSA progression-free survival, overall survival, quality of life related to the health, radiographic progression-free survival, PSA response rates, pain response, clinical PFS, adverse events, and health economic analysis was taken. What were the risk factors for early treatment failure on enzalutamide? First is LDH more than upper limits of normal, ALP more than upper limit of normal, albumin less than 3.5, de novo metastatic disease at diagnosis, less than 3 years since diagnosis, more than 5 bone mets were taken, visceral mets, PSA doubling time less than 84 days, pain requiring opiates more than 14 days, and prior abiraterone patients. And in PET scan also they have taken the SUV max more than 15 at one site and more than 10 at all measurable sites. And the characteristics were comparable in both the arms, in which they have taken median age of 71 years in both the arms. More than 20 PSMA avid mets were seen in 59% patient in ENZA versus 61% patient in ENZA plus lutetium therapy. De novo disease was taken and early docetaxel for hormone sensitive disease was given in 57% ENZA arm and 53% in ENZA plus lutetium therapy arm. And the patient with prior treatment abiraterone was seen in 11% in ENZA and 14% ENZA plus lutetium therapy. So we can see that baseline characteristics were comparable in both the arms. This is the experimental arm in which they have done the baseline PET scan. We can see the disease burden at the starting, and they have started the patient on enzalutamide 160 mg OD. And at the day on after day 15, they have given 2 doses at the interval of 6 to 8 weeks lutetium therapy. And at day 92, again the PET scan was repeated. PSMA PET scan was repeated, and we can see the disease burden at baseline and after the 2 doses of PSMA lutetium therapy. We can see a significant difference in the disease burden in both the images. And after that, they have given again 2 doses of lutetium therapy at the interval of 6 to 8 weeks. And in this, we have seen that radiographic progression-free survival was better in the patient receiving lutetium plus enzalutamide versus enzalutamide alone in metastatic CRPC patients. 81% patients were able to receive the 4 doses of lutetium therapy versus only 11% patients received 2 doses. In this, we can see that PSA progression with survival was much better in enzalutamide plus lutetium therapy arm as compared to enzalutamide. As we all know that enzalutamide and lutetium therapy have a synergistic effect. Enzalutamide increases the PSMA expression on the cancer cells, increasing the uptake of lutetium on the cancer cells, increasing the response of the cancer cells. Along with that, enzalutamide also increases sensitivity of the cancer cell to radiation so that they can undergo cell death. We can see median PFS was 7.8 months in ENZA versus 13 months in ENZA plus lutetium therapy arm. Similarly, in radiographic progression with survival also, we can see a PFS of 14 months versus 17 months in ENZA plus lutetium therapy arm. So the secondary endpoint were overall survival time and the health-related quality of life. We will discuss later. In this, we can see that overall survival also was much better in ENZA plus lutetium therapy arm as compared to enzalutamide. HR ratios are also favoring ENZA plus lutetium therapy arm versus enzalutamide. Median overall survival was 26 months in enzalutamide versus 34 months in ENZA plus lutetium therapy arm. Also, 38% of the patient on enzalutamide alone received 170 lutetium therapy as subsequent treatment of protocol later on. Now, in this study, they have also discussed about the quality of life, looking at the physical factors and the overall health. In this, we can see that physical function was much better in enzalutamide plus lutetium therapy arm as compared to enzalutamide arm, 10.6 months versus 3.4 months. Similarly, the overall health status was better in enza plus lutetium therapy arm as compared to enzalutamide alone arm. In this, they have seen the fatigue and the pain scale in the patients. We can see easily in these graphs that the patient who have received enzalutamide alone in metastatic CRPC settings have more fatigue as compared to the patient receiving enza plus lutetium therapy arm. In the similar way, we can see the pain scale in the enza alone, which is much more as compared to less pain in the lutetium therapy plus enzalutamide arm. And adverse events were comparable in the enza versus enzalutamide plus lutetium therapy arm. Only 1 to 2 adverse effects which were more seen in enza plus lutetium therapy. One was dry mouth and one was anemia, which was seen much in enza plus lutetium therapy arm. So at the end, the limitation of the trial was first the inclusion criteria. They have taken the first line enzalutamide in the early MCRP setting, pre-chemotherapy basically. And we need much more phase 3 trial also to look for the impact of enza plus lutetium therapy in metastatic CRPC settings. So basically, we want to see that whether PSMA replacement therapy in prostate cancer be administered more broadly in conjunction with all androgen receptor pathway inhibitors. So we will be waiting for the phase 3 trial results to look for these therapies. At the end, we will conclude that if we combine lutetium therapy with enza, we can see a significantly improved overall survival in men with CRPC, and also we can see there's good response in the patient who has early risk factors for enzalutamide failure. And we can see 8-month survival benefit compared to the active comparable arm. And also the combination also improves the deterioration-free survival and both health-related quality of life, like pain, fatigue, physical function, and health status was better in enza plus lutetium therapy as compared to enza alone. Thank you.
Thank you very much, Dr. Neha. It is a very good presentation presented by you, and it's very eye-opening also. Why? Because generally, my perception and most of our consultants' perception is after giving lutetium, patients require a lot of blood and transfusion, and they are dependent on that. But obviously, they have used in the first line, so there may not be the problem. But we use usually lutetium in the later lines, after 2 or 3 lines. Then this problem is very eminent. In your study, in this study which you have presented, they have done very well, and it's very gratifying that enzalutamide and PSMA lutetium act synergistically. So hopefully this study can convert into the our practice also. But yes, wherever is lutetium available, we can try for this. So thank you very much. Yeah, what is your opinion, Dr. Neha?
Sure, sir. So actually, in my opinion, also in my experience, also we have given lutetium in second or third line only, not in the first
Yeah.
line. But looking at this study, we can move away forward for this combination.
Maybe, but the only problem I could guess is this haven't
Availability.
compared with the availability is available in most of the center now. But the thing is, it has not been compared with the docetaxel arm, so
Exactly,
we
sir.
don't know the actual the overall survival benefit there is not or yes. So, but still, it is an eye opener because you have said like both the things act synergistically, which is never said before or never seen before. So
Yes,
obviously we can try in the later lines also, maybe the dose reduction or sometimes we can do some adjustments also. Sometimes if patient we have given lutetium therapy and patient feel weak, then in between we can start enzalutamide at least. We can do
exactly, sir.
this kind of the manipulations. Obviously, yeah. Thank you very much, Dr. Neha, for
Thank you,
being
sir.
with us. Yeah, thank you. So now I would invite our next speaker, my good friend, dear friend, Dr. Bhavesh Palodia. So we were there together in Tata Memorial Hospital. So we have a lot of memories to share. And now today for this discussion, uh, he will be speaking on the uh, one meta-analysis which demonstrate this is a very small print actually. So can you share your title, Bhavesh?
Yes, yes.
Bhavesh is a consultant medical oncologist in the Thangam Cancer Center, Namakkal, Tamil Nadu.
Thank you,
So
sir.
Wolverine study, yeah, this is so
Yeah,
worldwide oligometastatic prostate cancer meta-analysis leveraging individual patient data from randomized trial analysis from the XMED collaboration. So you can take over, Dr. Bhavesh.
thank you, Dr. Asim. It's always nice to be amongst all the people, especially when you are there and you are conducting a meeting. And thank you for the opportunity. So we are going to discuss something different than what we have discussed in last two lectures. This is something different which we usually don't practice a couple of years back, but now slowly this is gaining importance. That is the oligometastatic prostate cancer. So everywhere we are seeing that oligometastatic patient across all the subtypes of solid tumors, they are getting a separate entity, and we are trying to see which are those patients who, even though they are stage 4 and metastatic, but they have limited metastatic, and then they can be offered cure. And the most fascinating part of this presentation is the name, the X-Met. It looks sounds like X-Men and Wolverine. So very interesting data. So let us go through this data and understand what the authors wanted to say. So a basic introduction or the need, why there was a need of this IPD or individual patient data was that we have a lot of prospective randomized data which exist in this particular subsite of prostate cancer in oligometastatic setting. But that metastatic directed therapy is very limited, mainly smaller phase 2 trials only. So it has been hypothesized before also and now also that which patients may or may not get benefit with the use of this metastatic directed therapy. But the subgroup analysis, if we see, is very, very limited, and we don't know exactly who is going to fare better. Like we do it in breast cancer in oligometastatic, we know that hormone positives probably are the best people who may have the best benefit out of the metastatic directed therapy. So currently, what we have is a phase 2 randomized trials, and we have seen those data in various eras. We have a boom of new medications in last 10 to 15 years, and we have seen a lot of medications which are coming in this subsite of prostate cancer. Not only medicines, but also the imaging part, we have seen it is growing very rapidly. So coming to the trial per se, the goal of this XMED collaboration was to include all the randomized data which is available in oligometastatic setting, and then compile it according to the individual patient data. So the different publications were identified, and the main criteria was to keep oligometastatic definition as less than 5 mets, having prostate cancer, and who have received metastatic directed therapy, plus the standard of care versus the standard of care alone. And the point of interest or the endpoints were the PFS, the radiological PFS, the CRFS. This is something what we usually don't see in many of the trial, but this is something what we should look for, that is castrate resistant free survival. So till how you can keep the patient hormone sensitive and not become a castrate resistant, because we know this CRPC patients are very difficult to treat. And last but not the least, the most important what we always see is the overall survival. And there are two parallel analyses which were conducted, the meta-analysis using the common and random effect models to calculate the pooled hazard ratio and also the Cox regression. So both the parameters, both the parallel analysis will be seen in each and every slide. So this was across the globe, mainly the centers from US and Europe, the including the Comet, the Extend, the Oriole, the Stomp, and the Arto trial. So these were the main 5 trials which were included, and this amount to close to 472 patients, which were randomized to receive either standard of care versus the metastatic directed therapy plus the standard of care. And when we see the patient characteristic, they were almost similar, not much skewing of any of the parameters as we can see from this table. Coming to the main point of interest, that is the progression-free survival. This is something which is the first endpoint which we get in any study. And side by side, you can see the trial level analysis and Cox regression, and both show quite impressive data, where the the hazard ratio is quite impressive for the trial level analysis, and the Cox regression shows HR of 0.45, and the difference is almost double, 15 months versus 32 months when we give metastatic directed therapy. Coming to a specific PFS subgroup of interest, as we can see all the different subgroups as from this forest plot, CRPC at baseline or primarily whether treated or not, cancer stage, whether node positive, metastatic or just metastatic, imaging modality which was used, the number of metastasis or the ADT among the CSPC. Almost everything was showing improvement with the use of MDT, and all the Cox regression analysis also shows an excellent HR of 0.45. So almost 55% of the patients were getting benefit with the use of MDT. Coming to the second point, that is the radiological PFS. And again, here it shows improvement, and the diamond shows that the use of MDT has improved the radiological PFS. Cox regression also shows a HR of 0.59. So that shows that almost 41% of the patients were benefited. And again, there was a more than 14 months, more than 1 year difference of radiological PFS with the use of MDT. Coming to this specific output, that is castrate resistance. So freedom from castrate resistance is something very important, because we know once the patient goes into CRPC, it's a very fast progression. And here also it has shown a positive result. And we can see from the trial level analysis and the Cox regression that there is a good HR of 0.58. Again, 42% of the patients are getting benefited. And there is an improvement of close to 9 months between the two arms. And coming to the last but not the least, that is the overall survival. Again, the diamond is towards the use of MDT. It shows the benefit of the use of MDT. But if we see the HR, it is just crossing 1. It is 1.01 is a higher upper limit. So we can say that definitely clinically meaningful, but maybe statistically, if you ask me, probably it is not significant. But yes, the numbers are different, and if we see by the absolute number, there's a difference of more than 12%. So if we come to the summary of all the 4 main points, if you see the Cox regression and the random effect model, both are showing almost similar results with good HR for PFS, radiological PFS, and castrate-resistant free survival, except for the OS where it is 0.64. The HR is good, but unfortunately the confidence interval is crossing unity. So what we come to, what do we analyze from this is this is one of the very important and nicely done published data which have pulled all the patients, individual patient data from the oligometastatic subsite, and has shown a significant improvement in the PFS, RPFS, and CRFS. MDT also shows that there is an improved OS, even though the p value was not significant, just close, just missing the point. in the random effect model. And this MDT actually had, if you see across all the subgroup, whether untreated primary or staging, different type of staging imaging or CRPC, CSPC, and treatment with or without ADT, everybody is getting benefit with the use of MDT. So we should not make a mistake of putting or labeling these patients as metastatic and not giving option of cure or maybe a long-term survival. So these patients should be identified and treated separately, especially those who are having less than 5. So these are all the future directions of the ongoing trial. And we can see across all these 5 trials which are there on the chart, everybody is using a criteria where they are not crossing more than 5 as the metastatic site. Different modality of imaging, either bone scan, CT scan, or PET scan has been used. Majority of them are using either de novo or recurrent. Only one of them, Stampede, is de novo alone, and Starport is using recurrent alone. Most of them are having a PFS, the primary endpoint is a FFS or CRPF free survival, CRPC free survival, OS for oligometastatic in Stampede 2, and again radiological PFS in StarMet. So the sample size are almost similar to this trial, the IPD trial, close to 400 to 500 patient. Only the biggest trial, what we see is a Stampede 2, where it is close to 2000 patients. So these reports, these results will be there in few years, and probably will be, till that time we should keep these patients in our goal as a mainly for the curative setting, and not labeling them as palliative and not give them the best treatment. So I'll stop here, and thank you for the patient listening.
Yes, Dr. Bhavesh.
So what I understand is definitely what we have to make this oligometastatic as one of the separate group and treat them with curative intent, or best what we can say minimum is the long-term survival. So I think we should give them MDT plus the standard of care.
Yeah, that is actually my voice is going.
Your voice is echoing.
Now it's okay. Huh?
Now it is better. Now it is better.
Yeah. So, Dr. Bhavesh, we always had a concept in our mind like oligometastatic disease behave differently in the prostate cancer, especially even if not in the breast cancer, but prostate cancer, because the pace is slow, so they behave differently. And it was the narration before also that limited stage disease or less metastasis can be cured. So, and even in the metastasis in the different organ, they have given the liberty to use the uh, cancer-directed therapy to the prostate also.
Yes.
Curative intent. So prostate is a little bit different cancer, and this you have presented the meta-analysis where you said oligometastatic disease should be the patient should be given the chance to survive for the curative intent. So it's
Yes.
very good, and you have given the talk very nicely. Thank you very much, Dr. Bhavesh, and
Thank
we'll
you.
see you soon in the meeting very shortly.
Sure.
Thank you.
Thank you.
Now, there is some change in the meeting. Dr. Rohit Swami has some important issue and he has some emergency. So I am calling him little bit earlier than his schedule. So Dr. Rohit Swami is the consultant medical oncologist in Narayana Multispeciality Hospital, Jaipur, and he will be speaking on the Erasense trial, Erasense subgroup analysis, and darolutamide updates from ESCO GU 2025. So, Dr. Rohit, over to you. And I'm so sorry for the next speaker who has been postponed for a little bit time, Dr. Sneha Goyal. So, Dr. Rohit, first you will speak and then Dr. Sneha Goyal.
Yeah, good evening and thank you, Asim sir, for considering me for the early presentation of my slides. So, good evening, everyone. I'll be presenting RSN study as well as recent ESCO GU 2025 updates about darolutamide. Next slide, please. Next slide. So, key clinical trials in setting of metastatic HSPC, what has been history for the treatment of metastatic HSPC. So, in 2014, we came to know that addition of docetaxel to the ADT gives a survival benefit as compared to ADT alone in HSPC setting. And gradually, latitude stampede study also showed that first line abiraterone with ADT gives a survival benefit as compared to ADT alone. Titan, Archies, and Enjamet study showed that androgen receptor blockers in the first line can also give survival benefit as compared to ADT. And then came the trials which showed that the triplet has further benefit as compared to doublet, like PEACE-1 and RSN study, which shows that androgen receptor or abiraterone along with docetaxel and ADT in metastatic HSPC setting can give survival benefit as compared to chemotherapy plus ADT. So these all study proved that ADT alone is not sufficient. A patient who is on ADT will gradually convert in metastatic CRPC within 1 to 3 years. And addition of these chemotherapy or androgen pathway inhibitors may lead to increased survival as well as increased time to conversion to CSPC. Next slide, please. So, coming to all of these studies, there was significant survival benefit with addition of something, either chemotherapy or androgen receptor pathway inhibitors like abiraterone or androgen receptor blockers like enzalutamide, apalutamide, or darolutamide, along with ADT as compared to ADT alone. And then triple therapy, PEACE-1 showed that ADT, docetaxel, and abiraterone as compared to ADT plus docetaxel gives us a good survival benefit. And Arasens was the study which showed that combination of dosi and darolutamide along with ADT gives us survival benefit as compared to ADT and docetaxel alone. Next slide, please. So coming to darolutamide, darolutamide is a potent inhibitor of androgen receptor, and the important thing is that blood-brain barrier crossing rate of darolutamide crossing blood-brain barrier is very low as compared to other androgen receptor blockers, leading to decreased side effect, decreased CNS side effects, which are generally seizures when the androgen receptors blockers are combined with chemotherapy. And the design of this unique molecule also lead to decreased interaction with the other drugs. Generally, the patients who are having metastatic HSPC or CRPC are having the age of 70 or above, more than 70 year of age, and have several comorbidities and are on several drugs. So it is very much essential that the drugs we are using for prostate cancer should have minimum interaction possible with the most commonly used drugs for these comorbidities. So darolutamide as compared to enzalutamide and apalutamide has less interaction with the known drugs with less severe reactions or interactions with these drugs. Next slide, please. Coming to RSN study, so it was phase 3 randomized study which compared darolutamide, ADT, and docetaxel triplet with docetaxel and ADT. A patient was randomized in 1:1 patient, and the patient included one metastatic HSPC in the first line setting with good PS. And these patients were further stratified according to extent of disease, whether it was M1A, M1B, or M1C, and alkaline phosphatase level. And primary endpoint of this study was overall survival. Secondary endpoint was time to castration-resistant prostate cancer, time to pain progression, symptomatic skeletal event-free survival, time to first symptomatic skeletal events, time to initiation of subsequent anti-neoplastic therapy. So all of these are the proxies to time to progression-free survival. Inclusion criteria were metastatic adenocarcinoma, prostate, hormone-sensitive disease, which has not received previously any second-line androgen receptor inhibitor or ADT less than 12 weeks, and which are fit for ADT and docetaxel combinations. The patient excluded were the patient who had received ADT for more than 12 weeks or who had received androgen receptor inhibitor second generation or who are on CYP17 enzyme inhibitor drugs like ketoconazole or other antineoplastic therapies who had received radiation or who have any kind of severe uncontrolled comorbidities. Next slide, please. Coming to primary endpoints, so there was significant survival benefit with the addition of darolutamide as compared to placebo. Median overall survival was not reached as compared to 48.9 months in placebo arm with hazard ratio 0.68. So there was uh, uh, risk of death reduction by 32.5% with darolutamide as compared to placebo, and patient 4-year survival rate was increased to 63% from 50% with addition of darolutamide. Next slide, please. Similarly, in the patients, next slide, please. Next slide. And this survival benefit was seen in all the patients who, whether they presented upfront as metastatic HSPC or had recurrent disease and are metastatic HSPC at present. So the patient who presented upfront HSPC was around 86%, showed significant survival benefit. Similarly, patient who had recurrent metastatic HSPC setting were around 13%, and these patients also had significant survival benefit with addition of darolutamide. Next slide, please. And the survival benefit was maintained in all the subgroups, whether the patient was having high volume disease or high risk disease, low volume disease or low risk disease. And definition of high volume and high risk diseases, as you all know, is the presence of any visceral met or more than 4 bone mets is for the high volume disease, and Gleason score more than 8 or more than 3 bone mets, visceral met, two or more than two of these risk factors consisted high risk disease. Next slide, please. Coming to the secondary endpoint, time to castration resistant prostate cancer in all the subgroups. So there was significant increased time to progression to castration resistant prostate cancer in all the high, whether it was high volume disease or low volume disease, high risk disease or low risk disease with addition of darolutamide. Next slide, please. Similarly, time to pain progression was longer in darolutamide arm, and time to initiation of subsequent systemic antineoplastic therapy was also longer in darolutamide arm as compared to placebo with docetaxel. Next slide, please. And there was significant and robust, next slide please, significant and robust PSA response in the darolutamide arm, right starting from the 24-week up to the maintenance of the treatment. The PSA response was significantly higher with darolutamide as compared to placebo. PSA 90 response was also significantly better with darolutamide as compared to placebo arm. Next slide, please. Coming to safety measures and adverse events related to the addition of darolutamide with docetaxel. So addition of darolutamide with docetaxel didn't lead to any much significant side effect. Rashes, hypertension, and seizure were numerically more in darolutamide arm, but it was not significant as compared to docetaxel plus ADT plus placebo arm. Next slide, please. So common comorbidities in prostate cancer, as we discussed, and as we know, next slide, please. As you all know, is hypertension, diabetes, cardiovascular problem, urological complications, depression, sexual dysfunction, or osteoarthritis or arthralgia, hypercholesterolemia. Next slide, please. And several patients are on several common drugs, which we know, different drugs for the different ailments, and all the androgen pathway receptor blockers like abiraterone, apalutamide, enzalutamide, and darolutamide. All of these four drugs have some kind of interaction with some of these drugs. Uh, as we can see that apalutamide and enzalutamide has most commonly seen interactions with most of these drugs as compared to darolutamide. Darolutamide have less interaction, and the only significant interaction is seen with atorvastatin or repaglinide, uh, repaglinide being used in diabetes mellitus. So use of darolutamide may simplify treatment management with low potential for drug-to-drug interaction and may result in additional monitoring or change to patients' co-medications. Next slide, please. So addition of darolutamide to docetaxel and ADT may lead to increased median overall survival of the patient, as well as 4-year survival percentage with addition of darolutamide is 63% as compared to 50%. And good quality of life or better quality of life of patient is maintained, as we saw that adverse events were similar in both the groups, except numerical high rashes, hypertension, and rate of discontinuation with darolutamide was around 17.3% as compared to 10.6% with placebo, though it was not significant. Next slide, please. So several questions are still unanswered, but we know that ADT alone is not a treatment option for the MHSPC, and volume is an aspect where we have to decide to add chemotherapy along with the androgen pathway receptor inhibitor, and both a high and low volume disease have similar benefit with treatment intensification. Next slide, please. And darolutamide is potent AR inhibitor. It lead to low risk of clinically relevant drug-to-drug interaction and giving us a survival benefit along with combination with docetaxel and ADT, and require minimal patient monitoring. Next slide, please. So coming to this ESCO GU 2025 update abstract 143, which did a subgroup analysis on ARISAN study. Next slide, please. This subgroup analysis was done to look that whether the survival benefit of darolutamide is maintained in the patient more than 75 years, or it is limited to only the patient which are less than 75 years, or whether the darolutamide had more side effects in the patient who are more than 75 years of age as compared to less than 75 years of age. Next slide, please. So, out of these 1,305 patients which were analyzed in RSN study, around 1,086 patients were less than 75 years of age, and around 219 patients were more than 75 years of age. Baseline characteristic of all of these patients were well matched in both the arms. De novo upfront HSPC was 85%, as was the intent to treat population in both the arms. And similarly, PSA median was around 30 in both the arms, as well as in the intent to treat population RSN study. Next slide, please. And most common comorbidities in the patients which were both less than 75 and more than 75 were cardiovascular, followed by bone and muscle related, which was mostly arthritis or arthralgia. And then it was metabolic, which was diabetes. And the more of these comorbidities were present in patients who were more than 75 years of age. Next slide, please. So if we see efficacy of addition of darolutamide as compared to placebos, there was significant survival benefit in both the patients less than 75 years as well as in the patient which were more than 75 years of age. Next slide, please. And time to conversion to castration-resistant prostate cancer was also longer with the addition of darolutamide in both the subgroups, less than 75 year or more than 75 year. Similarly, time to initiation of subsequent antineoplastic therapy was also longer in both the patients, whether the age was less than 75 or more than 75. Next slide, please. So among the patient who entered follow-up, higher percentage in the placebo group received subsequent life-prolonging systemic therapy, and these are mostly abiraterone. And use of chemotherapy was very much less in this age group. Next slide, please. And coming to the safety, so there was no increased safety concerns or increased treatment-related adverse event in the patient population more than 75 years as compared to patients who were less than 75 years. Uh, the treatment related adverse event which led to discontinuation of darolutamide in less than 75 year was around 13%, which was around 15% in more than 75 year of patients population. Next slide, please. So this subgroup analysis showed that the patient, whether they were less than 75 year of age or more than 75 year of age, there was significant benefit of adding darolutamide with docetaxel and ADT with almost comparable adverse events. Next slide, please. Next slide. And then this was another abstract which was presented in 2025 ASCO GU update, which was again subgroup analysis which compared the use of GCSF. Next slide, please. Use of GCSF as a secondary prophylaxis to maintain docetaxel intensity in this patient population of RSN study, and whether the use of darolutamide led to decreased intensity of docetaxel use or led to increased hematological toxicities, pancytopenia, or led to delay in the treatment uh, in the patients during the initial 6 cycles of the docetaxel. Next slide, please. So in both darolutamide as well as placebo treatment arm, more than 95% of patients received efficacious dose of docetaxel, which was relative dose intensity of more than 80%, and over 88% of patients in both the arm received docetaxel more than 85% relative dose intensity. So even after the addition of darolutamide, docetaxel dose intensity was well maintained, and GSF use was mostly done in 98% patients as a secondary prophylaxis, and it was around 63% of the patient used GCSF in the darolutamide arm as compared to uh, around 50% of patients which were on placebo arm. Next slide, please. And if we see, according to the ethnicity of the population, Asian Pacific region study population had more use of GCSF as compared to the North Americans and overall population. And GCSF was primarily used in the secondary prophylaxis in these regions. Next slide, please. And if we see overall survival as per the docetaxel relative dose intensity maintained, so even in the patient where relative dose intensity of docetaxel remained less than 85%, there was significant survival benefit in the darolutamide arm as compared to placebo. And in the patient where relative dose intensity was more than 85%, there was significant survival benefit in darolutamide arm. Similarly, time to PSA progression was longer in the patient who received darolutamide arm, whether the relative dose intensity of docetaxel was less than 85% or more than 85%. Next slide, please. And coming to the safety, use of GCSF as well as maintaining docetaxel dose intensity less than 85% or more than 85% didn't lead to any new significant treatment-related adverse event alerts. Febrile neutropenia in the patient who had docetaxel RDI less than 85% was around 21.6% patient, uh, as compared to 5.6% patient who has more than 85% of RDI. So these patients who required secondary GCSF prophylaxis had more febrile neutropenias and neutropenia, and that's why required secondary GCSF prophylaxis. But the use of secondary GCSF prophylaxis as well as RDI of less than 85% also didn't hamper the survival benefit provided by use of darolutamide. So, next slide. So, I'll conclude my session here. So, home takeaway message is that addition of darolutamide with ADT and docetaxel, whether in the patients less than 75 years of age or elderly patient more than 75 years of age, use of primary or secondary prophylactic GCSF gives a survival benefit as compared to placebo. Thank you. Thank you, everyone.
Thank you, Dr. Rohit, for this elaborative talk. And you have given the insight like how daralutamide is safe to combine with the docetaxel. Usually, we have some inherent fear that docetaxel patient do not do well with the side effect and all that. But still, in this category of the patient, you have spoken about less than 75, more than 75. Daralutamide can be added safely, and they have given the results. It's a very heartening situation. And the other thing is darolutamide do not cross the blood-brain barrier very significantly. So in the population where patient is little bit neurologically compromised, we can use this drug. And
Yes, sir.
earlier we had seen like enzalutamide crosses the blood-brain barrier too much actually. So it gives like some side effect of fall and fracture and some seizures. But still, and darolutamide has very few patients who had seizures, and that too
Yeah, and in
usually
combination with
for the
docetaxel enzalutamide,
yeah.
these side effect of seizures increases with enzalutamide as compared to darolutamide.
Yeah, yeah. And other thing is, in the first few slide you have said about the Erasmus trial and Eranote also. Eranote trial they have given like in ADT plus dolutamide can be used in the first line setting also. This is a
Yes.
very good thing because many of time we get the patient in the PS3 and more than PS3. So that time you can try with these two. You can say the less side effect drug, and we will get the results also. So thank you very much for being with us and thank you again. You had
Thank
given
you. Thank you.
yesterday also and today also. So thank you very much, Dr. Rohit. So now we will move to prostate session is over now, and now we will move to the kidney cancer talks. So first of all, I would like to invite Dr. Sheena Goyal. She is a consultant medical oncologist in the Medanta Hospital, Delhi, and she will be speaking on Cosmic 313 study. Triplet therapy improves PFS, however, no OS benefit in the first line clear cell RCC.
Good evening, everyone. Thank you, Dr. Asim, and the organizers for the kind invitation. I will share my slides. Are the slides visible and am I audible?
Yes, ma'am.
Are the yeah, okay, I'll start. Thank you. The topic, the slides given to me for discussion, the study that I'm going to talk about today is the Cosmic 313. These were the final results that were presented at the GU meeting. Cabozantinib used in combination with nivolumab and ipilimumab in previously untreated advanced renal cell carcinoma patients. So briefly, the study design, they took patients who were treatment naive, had clear cell component, intermediate or poor risk as per the IMDC criteria. These patients were randomized to receive the triplet regimen, that is the addition of cabozantinib to nivolumab plus ipilimumab, or versus placebo plus nivo-EP. The stratification was done based on the IMDC risk and the region. The primary endpoint of this study was progression-free survival, and secondary endpoint was overall survival, and additional endpoints like overall response rates objective response rates were looked into. So as we know, nivo-EP has been a standard of care. That is a doublet regimen for intermediate to poor risk RCC patients. So this study looked into the addition of a TKI, that is a cabozantinib, along with that. What the baseline characteristics of the two groups. So there were 428 patients in the cabo arm and 427 in the placebo plus nivo-EP. The median age was 60 years. We can see there were enrollment from the West and also 35% from Latin America or Asia. So looking at the risk group, out of the total, 75% were intermediate and only 25% were poor. PD-L1 status also, if you see, maximum number of patients did not have a high PD-L1. It was less than 1%. Anyway, PD-L1 is not a requirement for using ICI in RCC. So coming to the metastatic sites, the most common metastatic site was lung, followed by lymph node mets, and then the bone and the liver. So this was the updated PFS. So what we had seen in the initial paper that was presented and printed in 2023 was a progression-free survival benefit with a hazard ratio of 0.73. So the updated results show that the PFS continues to benefit with the addition of cabozantinib to nivo-EP. The median progression-free survival here was 45 months. And the median PFS in the triplet regimen is 16.6 versus 11.2 months with a hazard ratio of 0.82. So this was statistically significant. Coming next to the overall survival curves. So what as clinicians we need is to see at the overall survival data. So even at the longer follow-up, the OS has not shown any benefit, and it was comparable between two arms with a median OS of 42 months. So then they looked into the further subgroup analysis between the two IMDC risk groups, that is the intermediate and poor. So if we see the initial curves, then we can see that it was the intermediate risk group which actually showed the maximum benefit, the use of cabozantinib along with nivo-EP with an hazard ratio of 0.76 and median PFS of 22 versus 11 months. That is almost double. Whereas if they look into the poor risk alone, so that did not show a significant benefit. Rather, it was numerically little lesser. The overall survival was not better in either the intermediate or the poor risk group. So coming next to, in regard to the treatment exposure and the adverse events, we can see that the median average daily dose of cabozantinib that could be used was 22.4 mg. So we know the standard was 40 mg that was planned. And if you look at the number of EP cycles administered, so the recommended cycles of 4 was only given to 58% of patients in the cabo EP arm versus 70% in the doublet arm. Then those modifications also required was quite high in the triplet regimen. And any treatment-related adverse event leading to discontinuation of one or more component was almost in half of the patients. Among the treatment-related toxicities, if we talk, so the side effects were quite significant. The most common grade 3 to 4 toxicity was almost 75%, with the most commonly the liver toxicity with an elevated ALT and AST levels, followed by diarrhea and the skin toxicity. And So there were 60% of patients who required the use of high-dose steroids in the triplet regimen. And if we look into the all systemic immune modulating medications, including steroids and other immune suppressants, it was 70% in triplet versus 56% in the control arm. So as we had seen even in the initial paper, where the initial primary analysis, even the updated analysis show that the treatment had a higher toxicity profile when 3 drugs were being used. So then they also in this paper looked into an exploratory biomarker analysis. So this is interesting. What they did was they did an RNA sequencing data was done of all the tumor samples. And they had made some molecular subsets. There were 7 molecular subsets, though they did not show any difference. But when they did a deconvolution from this RNA sequencing data to look at the effect of cabozantinib on immune cell types. As we know, cabozantinib has multiple targets, and many of these targets are also present in immune cells. So if we look at this right side, we look at the green bar, how it has shown that the M2 macrophages level was actually associated with a predictor of overall survival. So, explaining this further, these M2-like macrophages, it is seen that when these are present, they confer a poor prognosis to the RCC, and it was seen high in patients who have visceral mets, in those who have a poor risk group. Because what these do is that they are involved in the tumor growth invasion, and they suppress the immune response. So when they looked into the outcomes for these patients who were M2-like macrophage high levels, we can see the PFS curve first. The red line shows the patients with the M2-like high, but not received cabo. That is, they received placebo, nivo, and EP, and we can see the PFS, the outcome is quite poor. Whereas the blue line, dark blue line, which is the addition of cabozantinib, has shown improvement. And this was also seen as the overall survival, but this is an exploratory analysis and needs further study, but an interesting concept, probably looking into the biomarkers as to which patients could benefit with such an aggressive regimen. So coming to the conclusion slide, the takeaways from this is that cabo-nivo-EP ipilimumab triplet regimen did improve the progression-free survival, but there was no difference in the overall survival, and even the overall response rates were similar. Also, the high rates of adverse events limit the drug exposure, the number of cycles as planned. So therefore, I think this is not the practice-changing study, because as the clinicians, we definitely want an OS data, especially with this much toxicity being added. But like I showed, the biomarkers high M2 macrophage had a PFS and OS benefit with the addition of cabo, as cabo was seen to probably suppress the bad effect of this M2 macrophages. So the standard of care continues to be a doublet regimen for now, and these triplets probably needs further investigation, and there are ongoing studies for that. With that, I would conclude. Thank you.
Thank you, Dr. Sheena. So my opinion is little different with this particular study. Before this cosmic study came into the picture, we had 3 patients. I'll share my real-time experience about this. So one patient was on the brain mets presented with the midline shift. So she was on the heavy dose of steroid. So that time we wanted to start, but in the presence of steroid, immunotherapy are not working, so we couldn't give the immunotherapy. So we started on the cabozantinib, right? And later on we added the nivo and EP. That time the case study was there about this triplet regimen. Later on we searched that, and one patient, she had a very troubling malignant pleural effusion. So she was on the nivo EP, and then she was not getting the response. So every third day, every second day, we need to tap the effusion. And one patient had the pericardial effusion, and he was also not getting the response with the nivo EP alone. So we, in this three desperate situation, we had to add the cabozantinib. And for God's sake, all 3 patients got the response. The only thing is, we quickly learned that the dose with the immunotherapy combination of cabozantinib is not 40 mg; it is 20 mg. So once you start with 20 mg, they will carry on with the response, and their survival is very good. So out of 3 patients, 2 patient has crosses the 2 year survival. So this may be some deviation with the facts in the real time situation. Cabozantinib dose is little higher, was higher in that particular trial. So maybe the lower dose adjustment required with the Nivo AP combination. So that may be the screwing point. Okay, thank you very much, Dr. Sina, for sharing
Thank
your
you.
experience.
I think okay.
Yeah, yeah. So, next speaker, I would call Dr. Mohit Saxena. He is a senior consultant in Department of Medical Oncology in the Marengo Asia Hospital, Gurgaon. So, he will be speaking on the Keymaker U03 trial, and which is the which investigate the novel immune and targeted therapy in the refractory clear cell RCC. So, Dr. Mohit Saxena, over to you. It's important study.
Oh, good evening, sir.
Good evening.
Thanks for the kind introduction. Just for division is that I am currently working at Manipal Hospital, Gurugram. So my slides are visible.
See, Mohit, what happens is in Delhi, na, doctors change very frequently the hospital.
I can understand. I
So
can.
actually, previously used to save the patient, doctors and their hospital name. But now I remove the practice because na, once you call next time, they are in the next hospital.
This happens, sir.
Please
My
continue.
slides are visible, sir.
Yeah, yeah.
Okay, sir. So, thanks, organizer. Thanks, Asim sir, for the giving the opportunity. So today we will discuss about key makers U03 sub-study 03B. What is that? Pembrolizumab and two things. One is the novel immunotherapeutic agent and another is target therapy. Combination of Pembro with both novel immunotherapeutic agent and targeted therapy combinations for advanced clear cell renal cell carcinoma. Of course, these are those patients who are already failed on many lines of treatment, maybe already exposed to immunotherapy. So idea is that whether the re-challenge to immunotherapy, of course, with the combination of either some newer immunotherapeutic agent or targeted therapy agent can work again, or if the patient has progressed on immunotherapy, that's all over. So it was phase 1 or 2 study, and we will just discuss about the substudy 03B part. So that was published recently. So by the Lawrence Albiges. So yeah. So this is the study design. The histologically confirmed locally advanced or metastatic clear cell RCC patients were taken to have disease progression on or after PD-1 or PD-L1 inhibitors in sequence or combination with VEGF TKI or vice versa. Means they were exposed to at least PD-1 inhibitors and they might have received the combination with the VEGF inhibitors or something like that. So at least immunotherapy they have been exposed to immunotherapy. They should have measurable disease and the current performance status should be more than 70%. Now, they have divided many of you can see in this randomization picture, but importantly, we should know the efficacy phase, which you can see that they have combined with the pembrolizumab. With pembrolizumab is common. It's always 400 milligram every 6 weekly in this trial. Okay. So they have combined with two things. One is novel immunomodulating immunotherapeutic agent. There's among this arm B1 is Pavonlimab. Now it is a CTLA4 inhibitor. You know about the CTLA4 inhibitor, is a cytotoxic T cell lymphocyte activating protein inhibitor. So that's similarly to ipilimumab. And in arm B2, they have combined with Favezelimab. What is that? That's LAG3 inhibitor. That's a new thing. That's lymphocyte activation gene 3 inhibitors. So that's another way of doing the immunotherapy. And on B3, they have combined with MK4830. What is that? That's ILT4 inhibitor. What is ILT4? It's immunoglobulin light transcript 4. So they have tried to enhance the efficacy of pembrolizumab with adding these things so that it might work. And of course, they have used the combination in the B4 arm. They have used combined with the belzutifan. That's of course we know that is hypoxia-inducible factor alpha 2 alpha inhibitor. So that's they have tried to combine with that. In arm B5, that they have combined. There is no pembro, but there is lenva plus belzutifan. So both are TKIs. There is no immunotherapy in arm B5. And in this control arm, of course, there is lenva pembro. Lenvatinib plus pembrolizumab was taken. So almost say if you look at the primary endpoint, it was overall response rate as per RECIST 1.1. And in the secondary endpoint was DOR, CBR, PFS, and OS. So these things which we'll discuss, of course, they were stratified based on the IMDC risk factor and prior treatment with CTLA-4 inhibitor also. So the CTLA-4 inhibitors were allowed prior use, but except in the arm B1 because pavonlimab is itself a CTLA-4 inhibitor. Now, if you look at the baseline characteristics, and of course, first we are talking about this arm B4, that is pembro plus belzutifan and lenva belzutifan and the control arm. So you can see that the CTLA-4 inhibitor use was allowed. Of course, the arms are well balanced in terms of sex, ECOG performance status, IMDC risk factors. Sarcomatoid features were taken, though number was not great. It was 7 to 17% around. And prior use of CTLA-4 inhibitor was around 35% in these three arms. So you can see that they have rather, in addition to PD-1 inhibitors, they were also exposed to CTLA-4 inhibitors. And they were heavily treated. And most of these 35 to 37% patients have been treated with 2 lines of therapy. And up to almost 50 to 40 to 56% patients have been exposed to 3 or more lines of therapy. So these are heavily pretreated patients. It's not like that just they have received one line therapy or so. So its results are important. Now, if you look at the, of course, the novel agent arm, then of course, prior use of CTL, they are also, branches are also well matched in terms of age, sex, ECG, performance status, IMDC risk factors, circumferential features, and prior nephrectomy. But of course, only WAM is itself CTLA-4 inhibitor. So its prior use is in this arm, prior use of CTLA-4 inhibitor was not allowed. In the rest of the favezolimab arm and MK4830 arm, it is almost 30 to 35%. In all three arms, of course, you can see they are heavily treated. 30 to 40% of the patients have received 2 lines of therapy in the past, and 45 to 55 patient have received 3 lines or more. So these are heavily pretreated patients. Now, of course, we want to see that what they got. So this is the thing which we can got. So if you look at the pembrolizumab plus convalumab arm, then of course overall response, 20 patients were there, 30% was overall response rate, median PFS of 5.5 months, overall survival not reached, and 25% of adverse grade 3 or more adverse event. So you can see there is some activity, of course not great, but with this CTLA-4 inhibitor, with the convalumab along with the pembrolizumab. But the experience with the other two immune agent was disappointing. You can see pembrolizumab plus favezolimab, there is 0% response rate. In the 20 patients, there is 1.6 month of PFS. Overall survival not reached, though they were well tolerated. The grade 3 or 4 adverse event were 11%. Similarly to MK482320 arm, in the 24 patient, there is 0% response rate. So there is 1.5 month PFS, 11-month OS, and 9% grade 3-4 adverse event. So other two agents were though well tolerated in combination with pembro, but they were not effective. So of course we can think that combination of with the other immunotherapy after exposure to PD-1 inhibitor is not much effective. Now, if you look at the combination with other things like what? Pembro plus Lenva. That is a Lenva, that's the standard which we are using in our clinical practice as well. So here the response rate is okay, 40% response of overall response rate in the 73 patient, 9.4 months of the PFS, overall survival not reached, and grade 3 or 4 adverse event are 49%. Similarly, if you look at the pembro plus belzutifan arm, then in the 62 patient, there was overall response rate of 19%. There was median PFS of 5.4 months, overall survival of 27.4 months, and grade 3 or 4 adverse event were in 42% of patient. So you can see there is some responses there when we combine with TKI, but it looks like that these responses are largely derived from TKI, not from the immunotherapeutic agent. And if you look at the lenvatinib plus belzutifan arm, that's both TKI arm. So you can see the impressive overall response rate of 47%, median PFS of 12.5 months, median OS of 32.3 months, and grade 3 or 4 adverse events were 60%. Of course, the toxicity is some issue, but this combination looks efficacious in among all these. So probably if a patient has been failed on immunotherapy like PD-1 inhibitor and received any other target therapy in the past, then probably HIF inhibitor should be combined with any of TKI, like in this study they have done with the combination with the lenvatinib. So the takeaways here are, if you talk about the targeted therapy, the lenvatinib plus belzutifan shows best efficacy with adverse events requiring dose modification. So it is effective, but of course, if you look at the adverse event profile, the patient will require dose modifications. Pembro belzutifan and pembro lenvatinib benefit looks like largely derived from targeted therapy. It doesn't look like that pembro is helping. I think probably lenvatinib or belzutifan is playing the important role. If you look at the IO therapy arm, then pembro plus convolumab showed modest overall response rate and favorable adverse event profile. But PD-L1 inhibitor plus LAG3 inhibitor or ILT4 inhibitor showed no response, though their toxicity was low. So standard of care will remain targeted therapies with limited role of re-challenge of anti-PD-L1 after progression or IO. As we know about the same thing in the Nivo 2 trial, the tivozinumab plus nivolumab was tried, then of course the combination is as good as nivolumab again, or even combination was worse. In the contact 03 arm, cabozantinib was combined with atezolizumab, but cabozantinib alone was sufficient. The atezolizumab is not giving any additional benefit. Now, few words about the another HIF2 alpha inhibitor, that's casdatifan. There is ARC-20, that was phase 1 trial was there, that was dose escalation trial in the 2-line or more treated clear cell renal cell carcinoma patient. Now, in the primary outcome or adverse effect, though response rate was also there, that was not that good. Is 20 to 30% response rate was seen in this trial with the casdatifan given 50 milligram BD, 50 milligram QID, or 100 milligram QID in manner. And of course, this drug is tolerated. Of course, you can see that the adverse events were there. There were grade 3 or more adverse events were seen in almost 40 to 50% patient in all 3 doses. But the adverse event leading to discontinuation is quite rare. It's almost dose reduction and dose discontinuation is quite less, whether it is because of anemia or because of hypoxia. It's almost, you can see that only 3% of discontinuation because in the 50 QIDR and not in 50 BD and 100 BDR. So this drug is manageable. So what is the idea? As I told you earlier, that it is time. I think we should think about combining HIF to alpha inhibitor with some sort of another TKI. In the previous trial, we were talking about lenvatinib, and this peak one trial, they are combining datifan with the cabozantinib in advanced metastatic clear cell RCC. Of course, prior PD-1 therapy was there, and these were, of course, heavily treated patients. So this trial is ongoing. We expect that its result will be out, I think, by first half of the 2025. Primary endpoint here is PFS, and key secondary point is OS, overall response rate, dose DOR and DCR. So with this, I would like to finish. Thank you.
Thank you, Dr. Mohit, for your nice talk. In 2021, when this belzutifan was launched in the VHL induced tumor, that time we have given one question to our residents, and it was very new concept to them. But now the trial has come, and do you think Lenva and belzutifan is option which can be offered to our patient?
So theoretically, yes, this trial was also showing that among the all arm, that was the arm that was showing the best benefit. That's PFS of around 40% or so. Though the toxicity is the concern, probably the ideal dose we have already experienced about the lenvatinib, that's the ideal dose we never be able to deliver to our Indian patients. We have to reduce those. So probably the conceptually it's correct because the mechanism of action is different. The HIF alpha 2 alpha inhibitors are different, and if we combine with the TKI, then they should work. So conceptually, it's correct, and those toxicity might be concerned, so we might have to reduce the dose. Of course, I have not used this drug so far with the belzutifan.
Yes. Yeah, that is true. I guess both the drug doses has to be reduced before we can start to our patient. Our patient are a little bit lower in the body weight and stature and their protein content. Yeah, that may be the difference in the Western population and our population. Okay, but thank you very much, Dr. Mohit. Uh, and now I will like to invite next speaker, Dr. Ani Shrikant, and uh, he's a consultant medical oncologist in the Harish Rinova Cancer Hospital, Rajmundry. So he'll be speaking on the chemi trial.
Yeah, thank you for inviting us, Samir sir. Yeah, I would like the organizers to share my slides.
The slides are visible.
Yeah, slides are visible. Yeah, so the topic given to me for today's discussion was evaluation of circulating kidney injury molecule 1, which is as a role of a prognostic and predictive biomarker in advanced clear cell RCC, which was a post hoc analysis of Checkmate 214. Checkmate 214, as we all know, is an immuno IVO plus IVO trial where it used ipilimumab and nivolumab combination in intermediate and poor risk advanced clear cell RCC population and compared with sunitinib. So coming to the methods, how this SCIM1 molecule, that is like kidney injury molecule 1, which was measured in serum at baseline and 3 weeks after the first dose, that is before the second dose. Investigators are also blinded about the values of this KIM1 and association with KIM1 levels and baseline and clinical outcomes were assessed by using Kaplan-Meier curves and KIM1 levels were used and assessed by using paid t-test. So I would like to highlight here KIM1 is the molecule which is generally a glycoprotein molecule which will get upregulated in proximal renal tubule injury. It was not a new molecule which was discovered recently. It is actually in literature from quite long time. In 2000, it way backs to 2000 and 2002, where people used KIM1 levels assessment as a prognostic marker or a predictive marker for acute tubular necrosis injury. And it has been also used in assessment of lead poisoning and accumulation of lead in proximal renal tubules. And now in recent usage of IVO, the KIM1 is used in this trial as a prognostic and predictive biomarker in the Checkmate 214. And it is also used in a trial using atezolizumab as an adjuvant option in a clear cell RCC, that is IM power 010, where again this KIM1 molecule was used as a predictive marker. So with this background, next slide. So higher baseline KIM1 molecules were associated with worse overall and progression-free survival. This is what we expected because baseline KIM1 levels, if they're high, when you see these graphs, like the red graph which is of low and the green graph which is of medium and blue graph which is of high. So the survivals were lower when baseline KIM values were higher. Next slide. So, and it is also associated that even if the early levels which were high, it correlates with the poorer outcomes and poorer clinical outcomes. But even after usage of first cycle of nivolumab and ipilimumab, if the usage of doublet immunotherapy here as a PD-1 molecule of nivolumab and a CTLA-4 molecule of ipilimumab, if it causes a decrease in KIM1 levels in early use after a use of first cycle, such as early decrease of these levels, KIM1 levels also prognosticated the disease variables. Next slide. So when we see if it is greater than 30% decrease from the baseline high values, the median overall survival was higher when compared to the people who are less than 10% change when compared to the baseline. That is 85 months versus 52 months. And if some levels are increasing, that is greater than 30% increase when we all expect it should decrease for the betterment of the patient, then the survival has dropped down to 26 months. So patients with 30% decrease in KIM1 levels after 3 weeks of treatment had an overall survival 3 times more longer overall survival, which is of median OS, and 17 times longer median PFS when compared to those with the 30% increase. Next slide. So now we all know in this small study that KIM1 is a highly prognostic biomarker. That is what it is saying, like what we see 1PQ11 co-deletion in oligodendroglioma, which is also a prognostic, predictive, and diagnostic marker. Here KIM1 was initially can be proven or taken as a prognostic marker, like higher baseline KIM1 levels associated with worse outcomes, or a predictive marker such as early decrease in KIM1 levels after first cycle of nivo-IP causes better survival than compared to the subset of patients who are having more than 30% increase in the KIM1 levels after initiation of the therapy. And as I have already noted in my initial slides, like in ETISO trial IM Power 010, the KIM1 is studied as a biomarker of minimal residual disease and benefit of IO in the adjuvant setting. So, but these are all baby steps towards identification of molecular biomarkers for immunotherapy, as we all want a proper biomarkers to identify who are responding and who are not responding, and even in early stages of usage of IO therapies. So instead of these, we are very happy to have these baby steps like KIM1 molecule to assess the response of the patient and to prognosticate and predict their responses. But these this is a small post-hoc analysis, but we need a prospective, validated, and large studies to reinstate this point. Thank you for the opportunity.
Thank you, Dr. Shrikant. So, but
Yes, sir.
I just wanted to ask how to assess this KIM1 molecule. It is in the blood or it is in the biopsy
Sir,
specimen?
actually, we can assess KIM1 molecule both in blood and urine, but here in this trial, they have assessed in blood. And however, the values of KIM1 is not standardized. There are various studies, like in acute tubular necrosis, there are some range of values. In adjuvant IOM, the values were different. But however, the whole study, they have uniformly taken some range of values, but they are still not validated, like our HRD scores.
Yeah.
Yes.
So, do you think like immunotherapy causes that much frequent acute tubular necrosis in the patient?
Sir, when I have seen the molecular papers on this KIM1 molecule, it generally what happens is when there is a lipid destruction in the lipid destruction or lipid uptake in the kidney in proximal renal tubules, this KIM1 molecule is upregulated. So there is something maybe because of cell turnover or probably the lipid destruction or like what we see lipid choline peaks in brain. So probably something associated with replication of the cells and lipid membranes, which would directly correlates with these KIM levels. When we use this, what we can say, immunotherapy agents, probably initial decline in this inflammatory process or whatever, the replication. However, I am not sure how, because immunotherapy takes time to respond. It doesn't switch in first cycle. I'm
No.
also not sure how it switches in first cycle, but early decline has shown some responses.
Let me share you one little incident with us. We were
Yes, sir.
treating one patient of the malignant mesothelioma in the second or third line. So we had started on the Atijo and Bev combination because she was exposed to the standard Pembro and platinums. So after 2, 3 cycles, she suddenly had some elevated serum creatinine level and anasarca type of the situation. So she was landed up into the ICU. That time she was rescued there, but after that, her kidney profile is not improved too much. Means it is still deranged. So we needed to continue discontinue the drug. So I guess there is a role of the KIM1 molecule assessment upfront or maybe after having some injuries to the kidney. So yes, this
Yes, sir.
biomarker, you rightly said it is a baby step to assess upfront, but it should be there, and it may be in the bigger way in the future, because as we are giving increasing in the immunotherapy, growing with the immunotherapy, and we are giving to almost many patients. So this kind of the situation will come occur very frequently, and if we can assess upfront and prognosticate the patient, it will be great.
Yes, sir. We can avoid financial and the drug toxicities
Yes,
both.
yes. Yeah.
Sir, and thank you, sir. Thank you for the opportunity. And I
Yeah.
know you indirectly because of this Asim sheet, which we use in BMT.
Thank
So
you.
thank
Thank
you,
you
sir.
very much, Dr. Shrikant. Thank you. So
Thank you.
now this kidney session is over. We will move towards the next arena, that is the bladder cancer. And for that, I would invite our dear colleague, Dr. Vibhor Sharma. He is a consultant medical oncologist and hematologist and bone marrow transplant expert in the JP Hospital, Noida, UP. So he will be speaking on the Checkmate 274 trial results. So Dr. Vibhor,
Yes, sir.
yeah, please, you can take over.
Sir, is my screen visible?
Yes, Vibhor.
Okay, sir. So, thank you, sir, for the opportunity.
But now you are in Asian hospital, right?
Yeah, Asian Hospital.
Okay.
But anyways, as you said, doctors keep changing, so never mind.
They never take the Delhi doctors or around the Delhi doctor and CR and all that.
Yeah, so never mind. So I'm going to talk about this trial of adjuvant nivolumab versus placebo in muscle invasive urothelial carcinoma, that is Checkmate 274. This is a practice-changing study. This was first published in NEJM in 2021. So basically, this is a very large study of phase 3 multi-center study which evaluated the role of nivolumab versus placebo in patients with high-risk muscle invasive urothelial malignancies following radical resection. The dose of nivolumab was 240 mg every 2 weekly for 1 year, and the primary endpoints were disease-free survival in the intent to treat population and in the PDL1 enriched population, that is more than equal to 1%. PDL1 was the method of evaluation of PDL1 was by IHC on a DACO 28.8 platform. The secondary endpoints were non-urothelial tract recurrent-free survival, overall survival, disease-specific survival in both the intent to treat and the PDL1 enriched populations. So the eligibility criteria were the presence of urothelial carcinoma, either from bladder or from the upper urinary tract. The bladder cancers were the majority, forming approximately 79% of the patient population. The patient should have undergone a radical surgery with R0 resection within the last 4 months, and there should be no evidence of disease within the last 4 weeks prior to randomization. Use of cisplatin and NSCT was allowed. The performance status was 0 or 1, and the high risk of recurrence, which was the eligibility criteria, was defined in those patients who had received neoadjuvant cisplatin as YPT2 to YPT4A or YP node plus. In those patients who did not receive cisplatin, it was PT3 or PT4A or P node plus. So these were the eligibility criteria. Coming to the results, this is a large study enrolling 709 patients across 29 countries. PDL1 enriched population was approximately 40%. Node positive patients were 47%, and prior cisplatin use was seen in 43% of the patients. The median follow-up when the study was originally published in NEJM was 20.9 months in the nivolumab arm. So the baseline characters were well matched. The median age was 65 years. As mentioned already, the patients were either in ECOG PS 0 or 1, with the 79% being urinary bladder origin, 40% being PDL1 enriched, previous neoadjuvant cisplatin having been used in 43% of these patients, and node positive approximately 47%. So this study met both the primary endpoints, that is the DFS in the intent to treat population as well as in the PDL1 enriched population was improved. In the intent to treat population, the median DFS was 20.8 months in the nivolumab arm versus 10.8 months in the placebo arm, with a hazard ratio of 0.7. So approximately a 30% improvement in the DFS in the overall population. If we come to the PDL1 enriched population, the results were even brighter, with a hazard ratio of 0.55, that is 45% improvement in the DFS in the PDL1 enriched population. The other secondary endpoints, that is the non-urothelial tract recurrent-free survival, was also better in both the intent to treat population as well as in the PDL1 enriched population. If we look at the subgroup analysis, it is notable that all the subgroups benefited with the use of adjuvant nivolumab, except for the upper urinary tract cancers. There only you can see that it is crossing the midline. Otherwise, everything it is in favor of cisplatin. The is in favor of nivolumab. I'm sorry. So those patients who had received NACT with cisplatin benefited more than those patients who did not receive NACT with cisplatin, mainly because they were cisplatin ineligible. Of the PDL1 enriched population, that is more than or equal to 1%, benefited more than those with PDL1 less than 1%. If we come to the treatment-related adverse events, the main reason for discontinuation was because of disease recurrence, not because of the adverse events. TRAs led to discontinuation in 12.8% of the patients, and most common TRAs which led to discontinuation of nivolumab were pneumonitis, rash, colitis, and an increase in ALT levels. Grade 3 to 4 TRAs were seen in 17.9% in the nivolumab arm versus 7.2% in the placebo arm. The most common TRAs seen in the nivolumab arm were pruritus, fatigue, diarrhea, and rash. Grade 5 TRAs, that is leading to death. There were 3 deaths in the nivolumab arm. 2 were because of pneumonitis and 1 was because of bowel perforation. So this was a practice training study which led to the approval of adjuvant nivolumab in 2021. Now in last year in JCO, an update of this study was published, that is adjuvant nivolumab in high-risk muscle-invasive urothelial cancer, expanded efficacy from Checkmate 274. So in the previous study, the median follow-up was 20.8 months. In this updated study, the follow-up duration is 36.1 months. So almost 3 years follow-up. And we know that in urothelial malignancies, most of the recurrences take place in the first 3 years. So those patients who don't recur in the first 3 years, they generally do not recur later. So in this updated study, they have published the updated DFS, the interim OS, and this has shown a consistent DFS benefit with nivolumab in both the intent to treat as well as the PD-L1 enriched population. Interim OS benefit has also been shown, and also there is a continuous benefit in the other secondary endpoints, namely non-urothelial tract recurrent-free survival, distant metastasis free survival, and PFS2. And no new safety signals were reported. So let's look at the findings in detail. The updated DFS was 22 months versus 10.9 months in the intent to treat population with a hazard ratio of 0.71. In the PD-L1 enriched population, it was 52.6 months versus 8.4 months. So a very, very significant benefit with a hazard ratio of 0.52. If we come to the interim OS, in the intent to treat population, the hazard ratio was 0.76. The median OS was 69.5 months versus 50.1 months. Whereas in the PD-L1 enriched population, the median OS was not reached in both the arms with a hazard ratio of 0.56 in favor of the nivolumab arm. The non-urothelial tract recurrent-free survival, again showing benefit in both the ITT as well as the PD-L1 enriched population. The same story we see with the distant metastasis free survival as well as in the PFS2. So in all these endpoints, the hazard ratios in the ITT population is in between 0.7 to 0.8, and in the PD-L1 enriched population, it is in between 0.5 to 0.6. So coming to the conclusion, this trial led to the approval of adjuvant treatment with nivolumab for patients with high-risk muscle-invasive urothelial cancer following radical resection. Nivolumab is to be used for a period of 1 year at given in a dose of 240 mg every 2 weekly. The extended 3-year follow-up also shows consistent long-term benefits in DFS in both the population groups. The interim OS analysis also shows benefit with nivolumab. So, and the benefit of adjuvant nivolumab was enriched in patients with increased PD-L1 expression. So that's the last slide. Thank you very much. And thank you, Dr. Asim, for inviting me.
Thank you, Dr. Vibhor. Very good study. Actually, high-grade urothelial cancer is the nightmare for the clinician because they recur very fast after the surgery, also radical surgery. But if we can give this much of longer survival for 69 months or 56 months, which is very, very unheard, so it is very good. And only, I guess, the prerequisite is to maybe it is like PD-L1 positive patient, they do better, but still, if you don't do the PD-L1, you can give the nivolumab.
Yes.
Yeah. And now the pay programs are there, so we can easily convert the patient into the treatment arm. Thank you very much, Vibhor. And now I would move to the next speaker. That is Dr. Syed Nisar. He is the associate professor in Department of Medical Oncology Scheme, Srinagar, and he will be speaking on the Niagara study. The role of perioperative durvalumab with chemotherapy in muscle-invasive bladder cancer associated with the higher CR rates.
Good evening, sir.
Yeah, sir.
Good evening.
Good evening. Good evening, sir.
Thank you for the opportunity. So can you share slides from your end? There's some issue.
Yeah, sure.
Yeah, yeah, sir. Just a moment. Just a moment. I'm just sharing the slides.
Yeah.
So, sir, slides are visible. So you are mute. Yeah,
Yeah. Just a second. Just.
sure.
So, very good evening, and thank you, Dr. Asim, for opportunity. So, I will be presenting an abstract which was originally presented by Professor Matthew Galiski. So, we know that the standard of treatment in muscle-invasive bladder cancer was neoadjuvant chemo followed by surgery, but after that, NEGM publication 2024, neoadjuvant immunochemo has now become a standard. So we'll be presenting additional efficacy and safety outcome as an exploratory analysis of impact of PCR on long-term outcome from NAGRA study. Next, please. Next slide. Yeah. So in NAGRA, the addition of perioperative durvalumab to neoadjuvant chemo demonstrated significant and clinically meaningful improvement in event-free survival and OS. And also we can see that there was 10% improvement in pathological complete response as compared to the chemo group only. And in addition, we have seen that there were no delay to surgery and no impact on patients' ability to undergo complete the surgery. So here we report the additional efficacy and safety results. So this is what we see at 1 year, the event-free survival 69 versus 76. And at 2 years, we can see that again, this is around 59.8 versus 67 point. So which was quite statistically significant. Next, please. So this is the schema of the trial. So study population, there were adults, cisplatin eligible, so T2 to T4A or N1 with M0. They could be both urothelial or urothelial with divergent differentiation on histological subtypes. And they were evaluated and confirmed for radical cystectomy. And of course, they should be eligible for cisplatin with creatinine clearance of more than 40 ml per minute. So we had a comparator which was standard of care, GEM plus cisplatin, and here in durvalumab group, we had cisplatin plus gemcitabine and durvalumab. So each group, they received neoadjuvant chemo every 3 weeks for 4 cycles. Then they were assessed for surgery, and after radical surgery, so in the GEMCIS group, they were followed, but in the durvalumab group, they received additional 8 cycles of durvalumab. And the primary endpoints were event-free survival, pathological complete responses. Key secondary endpoints was OS, and secondary endpoints were metastasis-free survival, disease-specific survival, immune safety. And there were some exploratory post-hoc analysis points like EF by PCR and OS by PCR. Next, please. So you can see that metastasis-free survival in the intention treat group in the DEVA plus neoadjuvant group versus the chemo group. So it reduced the risk of metastasis or death by 33%, which is quite significant. Next. So again, in the previous place, in the disease-specific survival, the durvalumab plus chemo group, it appeared much better at 2 years, 89.2 versus 82.2%. So it reduced the risk of death from bladder cancer again by 31%. Next. So there was significant improvement in pathological complete responses. So it was 27.5 versus in the comparator group, and it improved to 37.3%. So it is additional 10% improvement in pathological complete response. Next, please. If you see the patient characteristic, which was well measured in both the groups. So if we see age, the sex, the basic racial factors, ECOG performance status, renal functions, tumor stage, histology, nodal stats, and PDL. So they were well balanced in the two groups. Next. So event-free survival with the PCR and non-PCR. So the population, so the group which had pathological complete response, it was around 37% in the chemo-immuno group. So it fared much better than the non. But in either group, so chemo-immuno fared better. So 92% versus 85% in the pathological complete response group. And again, in the non-pathological, you can see that chemo-immuno group fared better than the chemo group only. Next. So again, if you see OS in PCR and non-PCR, PCR fared better, but in either the group, chemo-immuno fared better than the chemo group only. Next. So coming to the adverse events, so they were all tolerable and manageable. So in either group, durvalumab versus the chemo only, they had almost similar toxicity profile. So there was some discontinuation in the durvalumab, it was around 9%. Otherwise, they were almost matched. If you see grade 3 or 4 toxicity, it was 41% in the either group. And so treatment-related deaths, again, it was 0.6% in the both the groups. So they fared equally almost in the vis-a-vis toxicity. Next. So the immune-related toxicity, which already we know, so they were most of times were low grade, and the most common, which we commonly see in the clinic with other immune-related toxicities, hypothyroid in 10%, and others like hyperthyroid, dermatitis, renal, diarrhea, colitis, and pneumonitis. So pneumonitis, so 0.2%. So they were same. So they were reporting around 21% in the durvalumab, and most of them were grade 1 or 2 and mainly hypothyroid, and which were manageable with the replacement therapies. Next. So conclusion was that Niagara demonstrated statistically significant and clinically meaningful improvement in event-free survival and overall survival with a 10% improvement with pathological complete rate. In the durvalumab arm, the risk of MFS event was reduced by 33%, and the risk of disease-specific event was reduced by 31%. Perioperative durvalumab plus neoadjuvant chemo improved event-free survival and overall survival in both pathological complete and non-pathological complete response group in exploratory post-hoc analysis. Immune-mediated adverse events were mostly low-grade and consistent with the known profile of durvalumab. So this additional Niagara data further supports perioperative durvalumab with neoadjuvant chemo as a potential new treatment for patients with cisplatin-eligible muscle-invasive bladder cancer.
Thank you, Dr. Syed Nisar. It is about to practice change the things we have done in our clinical practice. And muscle-invasive the bladder cancer, we need to have a very good treatment because they recur very fast, and the distant metastasis rate is very, very high. So if durvalumab can mitigate the situation, it will be wonderful. So thank you very much for your enlightening talk.
Thank you.
And now I would like to invite our next speaker, Dr. Anabrasen Sekhar. He's assistant professor in ACTREC, Tata Memorial Hospital, Mumbai, and he will be speaking on INDUCT trial, that is neoadjuvant durvalumab with chemotherapy shows promise in upper tract urothelial cancers. Dr. Anabrasen, can you please tell your pronunciation of the name? It was a little bit.
Anabrasen, sir. Shekhar, you can call me, sir.
Okay, Anabrasen. Bye. Please.
Good evening, everyone. I would like to thank Asim sir for giving me this opportunity, and I would also thank everyone for joining at the late night. Can the organizer share the slide from their side? Is it fine?
So slides are visible.
Yeah, slides are visible. Thanks.
Yes.
So, As the previous speakers were discussing more about immunotherapy in bladder cancer, we are also going to discuss more about an immunotherapy, but in a slightly at the higher level, at the level of upper urinary tract cancer. So we are going to discuss about safety and efficacy of durvalumab in combination with neoadjuvant chemotherapy that could be either gemcitabine with cisplatin or carboplatin in patient with operable high risk upper urothelial tract cancer, upper tract urothelial carcinoma. Next slide, please. So next slide. So why we want to discuss more about upper tract carcinoma? Because it is a rare disease with often associated with poor prognosis, much poorer compared to the bladder cancer in nature. Main treatment modality is radical nephroureterectomy, which remains gold standard treatment for upper tract urothelial carcinoma. Until recently, we got the trial for POUT study design, which is a phase 3 study design in adjuvant setting where we used chemotherapy, which not only showed DFS advantage, it also showed advantage in terms of overall survival also. And why we want to go with neoadjuvant treatment as in many other studies, why we want to go with neoadjuvant treatment? Mainly because the better preservation of renal function, they're able to tolerate the treatment in a much better way. And also the neoadjuvant treatment part might take care of the micrometastasis and also help in downstaging of the tumor. Next slide. And what is the background behind the study design? Even though bladder cancer and upper tract urothelial carcinoma, they share similar histology, but it not often seen because what the molecular pattern trend is showing here is there was so much of receptor associated tyrosine kinase, which is seen with bladder cancer, but not so oftenly seen with the upper tract urothelial carcinoma. That is also there. And there is a different genomic landscape is happening over there. And why we want to try immunotherapy in this setting? As a previous speaker mentioned about Niagara study design, Niagara study design has shown a dual primary endpoint, which shown not only advantage in terms of patch CR rate, it also shown advantage in terms of if event-free survival at 2-year landmark, which is 67 versus 58. These data suggest there is some role for immunotherapy, and we can try this immunotherapy in upper tract urothelial carcinoma also. Next slide. And this is with respect to the index study design. It is a phase 2 study design because the per se the cancer is a very small area, rare disease, and they tried with the phase 2 study design. They taken patients with good performance status, and one key inclusion criteria is not only based on the biopsy, even the presence of cytology is positive also has been enrolled into the study design. With a TNM staging of less than T3 or N1 has been taken into the study design. Patient should not have any other metastasis at the other side. Primary endpoint for the study design is achievement of PATSIA, that is YPT0 for this patient. What they done with the study design is, if the patient creatinine clearance is good, that is more than 60 ml per minute, then they will be eligible for combination of chemotherapy with gemcitabine and cisplatin. If the creatinine clearance is in the borderline range, then they will be eligible for combination of gemcitabine with carboplatin along with immunotherapy. How many doses has been given? 4 doses of immunotherapy has been given for this patient every 3 weekly interval for 4 doses. After that, patient will be assessed for surgery. If they are operable, they will go for surgery, and post-surgical response has been assessed for the patient. Next slide. Coming to the study population, how the patient has been randomized into the study design. 50 patients has been enrolled. One patient withdrew because of the consent, and then 49 patients have been allocated between two arms, that is gemcitabine with cisplatin along with durvalumab and gemcitabine carboplatin with durvalumab combination. And this is how the study design goes down further. Next slide. This is with respect to the baseline characteristics. So the study is respectively similar, but when it comes to the carboplatin arm, the patient age is on the higher side. Possibly that might be one reason they have been suited carboplatin more compared to the cisplatin also. And the smoker percentage is slightly higher, probably because of the older age. They may not in the carboplatin arm, the smoking history might be lesser. And uniformly, the pelvic calcium system malignancy is predominantly higher in all this cohort, and T2, T3 lesion were on the higher side. So this indicates they're not taken very early stage cancer into the study design. They're taken relatively advanced stage cancer into the study design. Next slide. So one of the key difference in this study design is not only they taken the histological feature into the study design, they also taken based on the cytological factors also, and the discordant rate is very minimal. Next slide. This is with respect to the safety profile because we have a preliminary data which show how the drug is doing. One thing is very clear: when we use the drug in the neoadjuvant or immunotherapy in neoadjuvant or adjuvant setting, the side effect profile is relatively lesser compared to when we use in the metastatic setting. Here also, when we see the side effect with respect to immunotherapy, especially lesser, there is no significant adverse event or grade 3, grade 4 adverse event, even though number of cohort is very lesser. One thing I would like to notice, the important side effects like myocardial infarction or unstable angina is seen, and grade 2 event is close to 4%, probably because of the effect of cisplatin in the study design. Otherwise, majority of the patient had neutropenia, thrombocytopenia risk also slightly on the higher side. Possibly this is also contributed because of the chemotherapy arm rather than the immunotherapy used in the study design. Next slide. This is with respect to the use of neoadjuvant therapy, whether the renal function deteriorated after using neoadjuvant chemotherapy in this neoadjuvant combination chemo and immunotherapy in this patient. When it comes to usage of cisplatin based arm, there is not much significant drop in the renal function in such population. Whereas when it comes to gemcitabine and carboplatin arm, there is slight drip in renal function for such population. Next slide. This is with respect to the pathological response rate. The pathological response rate is 13% with the usage of durvalumab when it combines with gemcitabine and cisplatin. And when it combines with carboplatin, the PATCR rate is 5%. So yeah, there is some data we can combine because it is slightly better. Next slide. And the response rate is much better when we combine with cisplatin compared to the carboplatin arm. Coming to the limitation of the study design, there is only 50% of patient had biopsy. Biopsy is not mandatory for the study design. It is one of the limitation for the study design. And other limitation is there is no control arm with respect to platinum-based chemotherapy alone. There is no platinum-based chemotherapy arm in the study design. And for primary result, we may need to wait for another couple of years. And another one drawback I found out is there is no adjuvant chemoimmunotherapy in this patient. Probably one of the drawback with respect to checkmate study design in adjuvant nivolumab arm is the nivolumab they used only for 6 months. Even there, the result is fail compared to the adjuvant pembrolizumab. Possibly adjuvant immunotherapy, I would have been more interested also. Next slide. What are the highlights with respect to the use of this study design? It is one of the first completed neoadjuvant phase 2 study, phase 2 trial in upper tract urothelial carcinoma with combination of immunotherapy along with platinum-based chemotherapy. This study shows that this regimen is safe and doesn't negatively impacting the surgery also. And there is encouraging result in terms of residual disease, mainly when the cisplatin-based chemotherapy regimen is used. And we subsequently, with the basis of this encouraging phase 2 data, they are going up with the phase 3 data where the combination of chemo and immunotherapy used in inductory study design. With this, I would like to end this study. Thanks for giving me this opportunity. Thank you.
Yeah, thank you. Just a minute. Thank you, Dr. Anabel. You highlighted the very valid point. It is a very rare malignancy, but still we can do better in this particular subset of the patients. So actually, it's hard to get the patient of upper urothelial tract cancer, but whenever they comes, it is very distressing situation for us. And now I would have been invited to Dr. Jayashree Goyal, but she has other commitment. So if you can run the slide, I will speak about that. Dr. Jayashree Goyal has left because she has some other commitment and we had delayed her session. So can you display the slide? Tech team, please.
Yeah, just a moment. I'm just sharing the slides.
Yeah. So this will be the last session for the day. This session is sponsored by Merck, and the title of this session is Maintain to Extend, right approach to maximize overall survival in the metastatic urothelial cancer. Yeah, please change the slide. So just a minute, I need to set the things.
Sir, slides are visible?
Yes, yes. So milestone, the platinum eligible advanced metastatic urothelial cancer. The treatment started developed in the 1980s when the cisplatin came into the picture for treating this urothelial cancer. And earlier the survival was only 8.2 months. And after use of cisplatinum, it has increased to 12.5 months. In 1992, there was some combination appeared with the cisplatinum, and then the story began. And now in the 2022, when the Avelumab was approved for the maintenance of the maintenance treatment in the urothelial cancer, everything has changed. So you can see the median overall survival when you use the avelumab in the maintenance it is 23.8 month versus only chemotherapy 15.0 month. So that is improvement after the maintenance chemotherapy, maintenance avelumab. So you can change. Please next, please. So this is Javelin Bladder 100. On the basis of that, this avelumab was approved in the maintenance therapy. Avelumab first line maintenance plus best supportive care versus best supportive care alone. So they have taken the unresectable locally advanced metastatic urothelial cancer, and the patient number was very high. It was 700 patients. They were enrolled into the trial, and CRPR standard stable disease with standard first line chemotherapy arm. If they got response, that is, the response can be CRPR or stable disease, then only they were the part of the trial. If they had progressive disease, they have been removed from the screen fail. They have been screen failed. So the chemotherapy were given cisplatin plus gemcitabine or carbo plus gemcitabine. So there were less issue of the platinum eligibility. If they have the borderline creatine clearance, then carboplatin were used and they were allowed. So if the patient got the response, so they were screened for the trial, and within 4 to 10 weeks they could be enrolled into the trial. So the randomization was 1:1. Patient received avelumab maintenance therapy 10 mg per kg Q2 weekly plus best supportive care, and they were compared with the best supportive care alone. And the treatment were given until the unacceptable toxicity or progressive disease, or if the patient has withdrawn the consent. The primary endpoint was overall survival. The primary analysis population were all randomized patients in intent to treat analysis and PDL1 positive population. Secondary endpoints were PFS, OS, time to relapse, response duration, disease control rate, safety and tolerability, and the this patient-rated overall outcomes. Next, please. So Javelin Bladder 100, you can see the graph of the median overall survival. They have given, if you use the avelumab maintenance therapy, the median overall survival was 29.7 months. Instead of where the base supportive care was used, it was only 20.5 months. So there is a significant improvement in the overall survival, and the hazard ratio was 0.77. That means almost 23% patient got the benefit, and there were delay. There were more survival advantage, and the long-term outcome with the avelumab plus best supportive care are similarly reflected in the real-world population also, real-world practices also. Next, please. Yeah, so the Javelin bladder regimen can be tailored according to the practical consideration and individual patient needs. So that we are doing very well in our clinical practice. Next, please. Next. Yes. So there's the Javelin bladder 100 safety outcomes, long-term safety in overall population. We have used this drug in and out, and so we know like the maximum side effect is pleuritis and sometimes hypothyroidism. Some patients will have fatigue, asthenia, diarrhea, and infusion-related reactions, but they are very well controlled. And now, since 3-4 years, we are using this drug, so we have learned very well to deal with this kind of the side effect. Next, please. Next. Yeah, so median progression-free survival was 26.7 months in patients who are exposed to the what you call is avelumab maintenance for more than 12 months, and median overall survival not reached. If the patient will pull through to the more than 12 months, then it is the median overall survival is not reached till this date. 20% patient were exposed to avelumab for more than 24 months, and 28% patient were exposed to avelumab for 12 months, and 47% patient were exposed to the avelumab for more than 6 months. Next, please. Next. Yeah, the milestone on platinum eligible advanced or metastatic urothelial cancer. Next, please. This is a repetition. Yeah. So now we will have the idea of the other contemporary trial which have been done with this kind of the patient. Previously untreated cisplatin eligible locally advanced metastatic urothelial cancer. So phase 3 randomized trial of the nivolumab, that is checkmate 901 study, where it was given with the gemcis combination, nivo plus gemcis versus gemcis alone in the locally advanced or metastatic urothelial cancer. So the patient were randomized into 1:1 fashion, gemcis plus nivo versus gemcis and then Nivo was given every 3 weekly for the more than 24 months or up to 24 months or unaccepted toxicity or patient withdraws the consent. Uh, 11% patient received in this placebo arm or the control arm. 11% patient received the first line of the available maintenance following the response of platinum based chemotherapy. So there may be little deviation in the data. Next, please. Yes, you can see in the Checkmate 901 study, overall survival and the PFS. So overall survival, it was 21.7 month versus 18.9 month in the chemotherapy alone arm. And when the PFS was compared, it was marginally improved in the nivolumab plus GemCis arm. It was 7.9 month versus 7.6 month. So Nivo plus GemCis was associated with the improved overall survival 2.8 month and PFS 0.3 month. Next, please. Next. Yeah, the subsequent therapy, we can see if patient has been exposed to the Nivo Gem plus Cis or Gemcis Nivo, then avelumab was given in quite a significant number of the patient. In the Gemcis arm, it was given to the 27 patient. It is 9% of overall, and 2 patient in the Nivo plus Gemcis arm. So unfortunately, only a limited number of patients were on maintenance avelumab in the GC arm, and a higher percentage would have helped us to guess the results better. Javelin Bladder 100 was first reported in 2022 in the Checkmate 901 in 2023, still lesser immune checkpoint inhibitor used in the comparator arm. Next, please. So these are the why did previous trial fail? Yeah, so I am Vigor 130 Keynote 361 Checkmate 901 studies. So the difference they have shown is not very great, and this available maintenance, they have the little bit more improvement in the overall survival. Next, please. You can see the, no, you can change the slide. Okay. So the question is, could differential censoring explain the inconsistent result in the phase 3 trial investigating the addition of the PD-1 and PD-L1 inhibitor into platinum-based chemotherapy as first-line treatment in advanced urothelial cancer? The findings were analysis of the PFS curves demonstrated no differential censoring in IMvigor, Checkmate 901, and after sensitivity analysis of censoring was undertaken, PFS and OS benefit was lost in the Checkmate 901. So in this particular subset of the population, there were less benefit or there were no benefit with the Keynote and Checkmate 901. Next, please. So this is a summary study. You can. Okay, next, please. Okay, EV302, EV plus Pembro versus best placebo arm. Phase 3 open label study of the EV plus Pembro in untreated locally advanced metastatic urothelial cancer. Previously untreated locally advanced or metastatic urothelial cancer, the N number was 886 patients. They were randomized into 1:1 patient, EV plus Pembro versus Gemcis or Gem Carbo arm. And until the progressive disease or unacceptable toxicity, EV was given. Dual primary endpoints were PFS by BICR and overall survival assessment. 32% patient received first line available maintenance following to a response to the platinum-based chemotherapy in the comparator arm. Next, please. So you can see EV302 study overall and PFS outcome. This was a very good study where the graph was separated from the beginning. At the 2 month 2 month time, the graph started separating, and they keep on separating up to the 48 months. So it is a very good study. Median overall survival in the EV Pembro arm was 33.8 versus the chemotherapy was 15.9 months, and the PFS in the EV Pembro arm, it was very great. It is at the 12 month, 81%, 51% patient could be progression free. At the 24-month cutoff time, it was 37.1% of the patient were progression free in the EV Pembro arm, versus 21% patient had only progression free at the 12 month, and only 12.6% patients were the progression free at the the EV Pembro versus.
சரி எல்லாம் இந்த மீட்டிங் கிட்டிங்லாம் முடிச்சுட்டு வாங்க பேக் பண்ணிடலாம்.
ஆயிட்டியா நான் ஊருக்கு போயிட்டேன்.
Hello. Yeah, please change the slide. Okay, this is the EV302 safety outcome. The treatment related AEs, as expected, it is more in the EV plus Pembro arm. The most common side effect of the EV was the peripheral sensory neuropathy, pruritus, alopecia, maculopapular rash, fatigue. But diarrhea was common in the chemotherapy arm. Decreased appetite was common in the chemotherapy arm, and the neutropenia was more common in the chemotherapy arm. Please mute the rest ones. Next, please. Yeah, these are the pictorial depiction of that maculopapular rashes and the peripheral neuropathy. Next. So, proposed EV ineligibility criteria: if ECOG PS2 is or 2 or more than 2 is there, we should not expose the patient for the EV. Enfortumab vedotin. Hemoglobin A1C is more than 8, then they should not be offered enfortumab vedotin. Creatine clearance or EGFR is less than 45 ml per minute. Any corneal retinal abnormalities, because it causes significantly dry eyes and grade 2 or more peripheral sensitive neuropathy is there at the baseline, then we should not use the EV and Pembro combination. Next, please. Next slide, please. Yeah. Next. So in the real world evidences also, we can what can we learn from the real world data and our phase 3 efficacy data maintained in the routine practice. Next, please. Yeah, so United the avalanche study available real world evidences for available first line maintenance include more than 2,500 treated patients with locally advanced and metastatic urothelial cancer globally, with additional data upcoming in the conferences. So 509 patients they were taken from the United States, Europe. They contribute for the 325 patients, and Asia Pacific 1,051 patients. Next, please. So the survival outcome in the available first line maintenance are consistent with the real world data. PFS was 5.5 months in the according to the Javelin beta study. 12 month was 71.3. 12-month overall survival was 71.3% of the patient. So next, please. Yeah, Indian real world evidence on available maintenance is also consistent with the various randomized control trial and global this real world evidences. And this study particularly, I guess, this was done by the Vineet Talwar et al. In the ISMPO conference it was presented. So the median PFS was 5 months, and in patient who received Avilimbab for more than 6 months, with the median PFS was 11 months. The median overall survival was not reached up to the publication, and 12-month overall survival was 82.1 months. Next, please. So outcome with the EV plus Pembro in the real world and the other studies. So EV103, we will discuss the EV302. The overall response rate was 67.7%. 12-month PFS was 50.7 months, and the 12-month overall survival was 78.2. So it was quite impressive study, and the overall and 12-month PFS OS rates were comparatively low in the real world compared with the trial, because there might be the dose reduction. Next, please. Sequences of the therapies. In the Checkmate 901, there was no mentioning of the nivolumab plus gemcitabine. After you give this combination, what was the subsequent therapy? EV302, EV Pembro. After that, there is no data available which therapy the patient were exposed. And if after the Javelin greater 100, if platinum chemotherapy, then the Avilimab was given the best outcome with the and then the second line EV plus ADC were used, and in this particular approach there was a 40+ month survival benefit once you give the first line Avilimab maintenance. Next, please. A contemporary sequencing of the javelin bladder regimen followed by the second line enfortumab vedotin achieved a median overall survival of 40.8 months from the start of the first line maintenance that we have spoken about. Next, please. Yeah, summary. Next, please. So we have discussed everything in this. Next. Yes, this is an important slide. Median overall survival in trials of the first line treatment approaches. First line platinum followed by avulumab maintenance. It is like 27.9 month overall median overall survival according to Javelin Bladder 100 trial. First line EV plus Pembro, it is 33.8 month better EV302 trials result, but the availability of the enfortumab vedotin is questionable. It is not available in India. So the superiority in the India is till this date is Javelin Bladder 100, 29.7 month. First line Jamesis plus Nivo, it is 21.7 month. If you use the contemporary approach like platinum Jamesis, then it is 16.1 month. If you use platinum gem plus immune checkpoint inhibitor, it is 17 month according to Keynote 361 trial and so on. Next, please. So optimal sequencing is Genesis followed by avulumab maintenance. What was the conclusion? In a rapidly evolving landscape of the metastatic and locally advanced urothelial cancer, it is important to consider all treatment options to optimize the treatment journey for each patient. Avulumab first line maintenance can be tailored according to the practical consideration and patient need, including the duration, number of cycle, and response to first line patient-based care, the type of the first line PBC regimen, and length of the treatment-free interval prior to the maintenance. Due to the toxicity profile, a significant proportion of the patient may not suitable for the EV Pembro treatment, and therefore EV ineligibility criteria are warranted. So if patient has a diabetes, has neuropathy, has corneal irritations, they cannot be enrolled into the EV Pembro combination arm. One first line treatment impacts option of the second line choices also, highlighting the importance of evidence-based sequencing of optimized efficacy and minimize toxicity, and for patient profiling and the individualized the treatment. So next, please. Thank you very much for your patient listening. And with this, I will end this webinar today. And I must confess that we have learned many things from our speakers, our esteemed speakers, and the abstract quality of abstract is very good. And they shared their experiences, so we learned too much about this. And the continuous updation is the process where we can update our knowledge and impart to our patient. The urothelial cancer, kidney cancer, and the bladder cancer, they are changing very fast. The treatment paradigm is changing very fast. So updation is the utmost requirement of the today's era. For that, our academic partners were AstraZeneca, Cipla, Dr. Reddy's, Merck, Fresenius Kabi, Delac, Bayer, Glenmark, Natco, Izai, Samarth, and Ferring. I wish to thank all of them, pharma companies, and our technical support team, Team Horizon, and all the participant and audience who have made this success. The whole idea of keeping this kind of webinar is continuous learning and fostering the collaboration of the knowledge and the experiences. Thank you very much. Thank you. We'll meet in the next week also. Thank you very much.
Thank you, sir. Thank you, everyone, for joining. Thanks to our academic partners. Thanks to my colleague Dhruv and Swarangi for driving this 2 days academic program smoothly. Thank you, everyone. Thank you, sir. Thank you, technical support. Good night,
Thank you,
everyone.
ma'am.
Thank you, ma'am. Technical team, please close the meeting.